So good afternoon. Welcome to the weekly webinar series of Mycetoma Research Club. So a little bit about me. I'm Wasan. I work in northeastern part of Ethiopia, Boromeda Hospital, which is a dermatology referral center. And also I'm pursuing my fellowship in tropical medicine. So this is my presentation outline. So it's actually a clinical practice review over the past 2 years in Boromeda Hospital, which serves as a dermatology referral center. So we have around 5 dermatology centers in Ethiopia. So Boromeda is one of them. So subcutaneous mycosis are a group of chronic fungal infections which are affect the skin and underlying structures. So the most common subcutaneous mycosis are that of the mycetoma, chromoblastic mycosis, and sporotrichosis. So I want to specifically discuss about the mycetoma, which is a specific chronic granulomatous disease with tumor fraction and draining sinus and presence of grains. So based on the etiology, it's classified as mycetoma caused by the fungus and the actinomycetoma, which is caused by filamentous bacteria. So if left untreated, it has a devastating complication with destruction of deeper tissues. So geographically, the mycetoma belt encompasses 13 degrees north and 15 degrees south of the regions, and it was recognized by the WHO as neglected tropical disease, and like other neglected tropical diseases, with significant socio-economic impact, as it primarily affects the working or reproductive age group. So Ethiopia, it's estimated of 100 million population. So the Amhara region is the second largest region in Ethiopia, which has share a lot of borders with Sudan. And Boromeda Hospital is found in northeastern part of Amhara region. So the 2021-2025 Ethiopian National NTD Strategic Plan includes around 12 neglected tropical diseases. Out of them, 7 are skin entities. So by that time, which is in 2021, mycetoma was not included in the national strategic NTD plan. But as a report reported to the WHO, Ethiopia had the highest number of mycetoma cases after Sudan in sub-Saharan countries, as shown in the picture. Around 116 cases of mycetoma were reported according to a rapid assessment done in 13 referral hospitals in Ethiopia. But we don't know what happened to these patients. There is lack of data on treatment response of mycetoma patients in that literature. So what we did is we conducted a single center, a retrospective medical record of all patients, prior and new, and clinically suspected and biopsy confirmed cases of mycetoma cases who attend the Boromeda Hospital. So the hospital is located 400 kilometers from the capital Addis Ababa, and it's established in 1955 as a leprosarium by the Sudan Interior Mission, which is also known as the SIM, which is the American missionaries, and it serves as a referral and research center for dermatology and ophthalmology services. So the hospital serves in the neighboring regions, including the Tigray region and the Afar region, and from neighboring regions. So it serves as a catchment population estimated to be 15 million population. So the hospital has 1 dermatologist and 1 tropical dermatology expert, 2 general practitioners with dermatology training, and 10 nurses. And it has 3 dermatology OPDs and 1 dermatology referral centers. And most patients encompasses skin entities and has beds for leprosy and cutaneous leishmania patients. So we collected the clinical record from having variable of interest, including the socio-demographic data, clinical presentation, baseline investigations, and treatment regimens and outcomes. What we didn't do in these patients are that culture was not, and other species differentiation was not able to do, as there is a lack of these facilities. So charts were reviewed by the attending dermatologist. So we regularly do serial photography of mycetoma patients like other skin NTDs for the purpose of machine learning under visual DEX and project impact NTD, which is Melinda Gates funded project. So since we don't have other cure assessments, so dermatologist assessment of clinical response coupled with photography of lesions were used to assess the treatment outcomes. So the study included around 70 patients. So these are patients, we have more than these patients, but these are patients who have documented clinical outcome at approximately or in the range of 18 months. So we have 11 male patients and 6 female patients, and their age being 28 up to 64. Okay, so the majority of them were farmers coming from countryside, and the mean duration of lesions were 5 years. So we have patients who have these lesions more than this also. So the most clinical presentation being painful, painless foot swelling, and the foot was the most frequently involved site. So we usually do what this is the punch biopsy. I know it's an appropriate, is not an appropriate method to take punch biopsy, but for selected patients where we undergo surgical excision, we take also excisional biopsy. But in the routine medical OPD, in the busy dermatology OPD, we did a 3 millimeter punch biopsy. Okay. So for confirmed mycetoma lesions, we use itraconazole 200 milligram POBID and cotrimoxazole or Dapsone for confirmed actinomycetoma cases. So when conclusive biopsy results are not there, we use a combination of both. So 2 patients out of this undergo debulking surgery, and after a main follow-up of 18 months, only 3 patients have achieved clinical cure based on dermatologist assessment of lesions. So this is one of our patients. So is it visible, the pictures for you clearly?
Yes, yes.
Yes,
Okay,
yes.
Okay, so this was a 30-year-old male patient who came to visit starting from his age of 15 years. Now he is 13. So he has this lesion over the past more than 10 years. So he has swelling, tumefaction, and draining sinus, and sinus tractus. So initially we did an excisional biopsy, and as you can see, the excised part of the lesion containing black grains, having lesions, and this is 1 month after excision. So he has previous 7 surgeries, like 3 local surgeries and other 4 surgeries under general anesthesia. So this is what looks like 1 month apart, and itraconazole was also continued. And as you can see, there is a granulation tissue. So at 6 months, he has it looks like 15 to 75% of lesions were decreased in swelling. There was no at least visually visible sinus tractus. There was no visible discharging grains. Things were going okay for him until he was reevaluated in between, and this is the final mycetoma lesion what he's having. So At 24 months after follow-up, there is an increase in swelling, and there was new sinus tracts and discharging sinuses. And also in the imaging, he has osteolysis of second and third metatarsal and tarsal bones. Okay, so this is a patient. So this is a patient. So this is a patient who has. So who has undergone.
Fish.
And some mute. Okay.
Just continue, yeah.
Yeah, a patient who undergone unavoidable, unfortunate patient who undergone below knee amputation. So we have also other patients like who came from southwestern part to northeastern part of Ethiopia. So she has this lesion with discharging grain and difficulty of walking. And we have this biopsy result, which states as Mycetoma with a description. And she was put on itraconazole 200 milligram BID. So at 12 months and then subsequent follow-ups, and finally after 12 months, she has already decreased in swelling. There was no sinus tracts, and she was lucky she was able to work, and we are following her. So I don't know if you see a patient like this, a patient who has like which was treated like 10 years back, but who came with some after he has been ulcerated. Okay, so this was one of the cases where one of our patients who have
Wilson, we are losing you.
Amputation, but he came with new lesions again. If, I don't know if it is injured. Can you hear me, Professor? Now? Can you hear me?
It's clear. Yes.
Okay. So some of our patients have this tumefaction and spread to the local lymphadenopathy. So this was one of patients who had this lesion over the inguinal area, but even though he has decrease in swelling in the legs, but the swelling in the inguinal area seems to be there, and it's usually fibrous, and he's not getting much improvement. Okay, so our conclusion on the currently studied therapy that the most usually used therapies against mycetoma are suboptimal or unsatisfactory, and they are characterized by low cure rates, and which highlights the need for researches in the more effective therapy. So still in Ethiopia, gaps in advocacy and early recognition of mycetoma patients. So the capacity of health care providers is not well optimized, and identifying species still be a gap, and availability and the cost of drugs is another major problem for mycetoma patients in Ethiopia, and more researchers are needed to address this gap. This was the discussions that I want today, and these are my references I used. Thank you. So now the floor is open for discussion. Professor.
Yes. That Professor Fahal, who is going to...
Yeah, Professor.
Yeah, you are going to
you are the moderator.
Okay. Hello, everybody. This is one day. I'm the former teacher of Wasan. Wasan, thank you for your presentation. Wasan was assigned to Boromeda Hospital just, I think, a year and a half back. And this is the work he has done in the last almost 18 months. Also, this is some of the report. And this is something which we haven't seen before, documentation of treatment outcome of some of our patients. So I would like just to open the floor for some question or comments.
Hello?
Any question? I think.
Yeah, yes, please.
Yes, Professor Fahal. Yeah.
Thank you, Wendy, and thank you, Wesley, for this nice, elegant presentation on mycetoma in Ethiopia. And I think this is a very good start to do a very good work on mycetoma. I can see now you are documenting your cases clinically as well as photo. And this is a very important step for doing a proper research in the area. I noticed the second patient, the lady, was it an actinoblastoma or eoblastoma? Because I saw she's yes, this one, yes. It's an actino or eoblastoma, but clinically it looks like very much like an actinoblastoma. So was it eo or actinoblastoma from the investigations?
Yeah, so the investigations labeled, it was done by dermatologists, and it was labeled as an eoblastoma case.
Eoblastoma.
And
based on what? In histology or molecular or?
It was histology. It was histology, Professor.
Yeah, this is very good. I think this is a very good result. And you can see there's a good response to itraconazole after 1 year. And she was able to walk. This is very good. Yeah. I think, yeah.
This is the patient who has been traveling from the southern part of the country to the north, if I remember correctly.
Yeah.
And it was the outcome. I think I have seen this patient also when we visited his center last time. And one of the questions, I think, in addition to what Professor Fahal said, is, I think, did you plan any surgery and how is she doing now?
So the lesion appears the same as what we were seeing together over the past 6 months. It doesn't show any decrease or increase in the lesion. So on the palpation, it feels like firm, and it may need, I don't know, further surgical intervention, but the lesion seems to be there without increasing or changing size.
Yeah, I think you need to do some surgical. My advice is to have some surgical excision for this patient, because as you know, in mycetoma, it is a chronic granulomatous fibrous tissue infection. It will never go away without some sort of surgical excision for such a patient like this. The problem, the organism may be viable in this fibrous tissue, and it may break at any stage. The immune system may break and may have recurrence of the condition at this, and it may be getting worse and worse. So my advice, to have some sort of surgical excision for this patient, and continue on the medical treatment as well.
Yeah. Thank you, Professor. I think that's also my advice. Wasan, is there an opportunity to do also an ultrasound examination of this thing? And also, as suggested, actually consider based on that, on surgical excision and debridement.
Okay, so the soft tissue can be examined by general radiologists, but on the specific issues regarding ultrasound in mycetoma, they may not able to see it. I don't know how, they don't have this the experience, but the soft tissue can be commented based on the radiology response, and we can do it also.
we can help in the ultrasound examination.
Yeah,
If your radiologist can do the ultrasound,
they will do it.
And print out the photo and send it to us. I will send it to our radiologist and he can report on it.
Yeah.
Okay,
And this is
that will be good.
Yeah, that will be a start of the collaboration. And again, it is very easy for your radiologist to communicate with our radiologist to have some online session on the diagnosis of mycetoma, and that can be very easy done in your center there. And if you can go to our mycetoma website, you will find the SOPs for the ultrasound examination. And then your radiologist can follow these steps and proceed.
Is there a chance, Professor Fahal, to have our radiologist to attend like an online session while doing the radiology on the patient?
Yes, definitely, yes. Yes.
I think this will be much better because it's a combination of training and also of supporting and consultation for the local radiologists.
We can organize the Zoom meeting for both of them, and then they can communicate during the Zoom meeting and doing the examination and have the diagnosis settled between them.
Yeah, I think if we can just like set 1 hour per week during their clinic, and every time we can nominate one of our radiologists, this will help a lot.
Thank you very much. This is a very good suggestion, Abdullah. I will take this forward and then we do that. Wendy, what do you think?
Yeah, that's the best thing to do because I think the radiologists in Ethiopia, they're very much trained in many other issues and it's easy for them to catch up with those things.
Yeah,
and it will be a great support because the first thing is you have already mentioned it, Wasan. It's really because the biopsy examination 3 millimeter. I'm not sure why you are using it. 3 millimeter. Usually we use it for face. It's very small, and at the same time also, if there is a trained radiologist, it will be easy to do that ultrasound guided biopsy, which is advised by Professor Fahal's group. And plus also, as it's stated, the issue is we have to really standardize our treatment guideline, or at least our treatment practice. Thank you.
I cannot emphasize more than what Professor Wendy mentioned, that punch biopsy is not very useful in establishing the diagnosis of mycetoma because this is only dealing with the skin, and you may be lucky to find some grain in the skin. But normally, it is a deep-seated infection, a lot of fibrous tissue there, and difficult to get it from this bench biopsy technique. And as Professor Wendy mentioned that if you can combine ultrasound guided biopsy, it will be very useful to establish the diagnosis. The specimen can be taken for cytology, immediately you can have the diagnosis, or you can take more biopsies for histopathological diagnosis techniques. Abdullah, what do you think?
I think it's very crucial to identify the causative agent, especially that those patients are from climatic region, which is quite different from Sudan, and they might have other fungal causes, although the pathology looks the same. But we need to reach the grains, and biopsy without grains are use-disc biopsy.
Yeah. That's one of our plan, actually. I hope we are now waiting for the national ethical approval. We have an ethical approval for from to institutions for nationwide mapping in highly endemic area. And we are planning to screen around 100,000 people with this DNDi funded project. And the plan is just to get the training from the ultrasound training from you people, and plus do the biopsy, but at the same time also the project is trying to identify actually the causative organisms. We're going to do the qPCR. That's actually the what we are expecting in the next year. or this year, end of this year or next year, at the beginning of next year. Yeah.
Just
Perfect.
one comment about this patient. This patient, it seems, had responded very well to the itraconazole, and there is a dramatic decrease in the size of the lesion, which is not very common in cases with mycetoma. So I think we would like to have more in-depth knowledge about the organism causing this case. It may be one of the new organisms sensitive to the itraconazole.
Yeah.
Yeah, this is very unlikely to have this response for Madrella mystomatis if you treat with ketoconazole alone or itraconazole even.
Yeah. So let us.
Wasan, I think the best advice for this patient is you don't need her to end up like your first patient with amputation. So it's important to link for her and just do the examination, the ultrasound examination and the biopsy, and consider the surgical excision as early as possible. Because if it starts again, you may have the bone lytic lesion and again, actually a complicated ulcer and amputation. So this is a very great response, but to keep the momentum, just you have to really try your best, and this may be one of the most successful response you may have. Yeah.
Yeah. Yes. And try to keep these brains for sequencing in the future to identify the organism at the.
Professor Fahal, your voice is.
Yeah. Yeah. I told him just keep the grains for sequencing in the future.
Yeah.
Yes. Hello?
Kadima has raised her hands.
Okay. Kadima, go on. Kadima, you are muted.
Kadima, you may unmute yourself and start.
Right.
Okay, maybe I couldn't.
From the others, okay, till then. Yes. It's my mistake. Wasan, the other question I would like to ask you is that, because, you know, have you really tried to look from where your patients are coming? And also, how the accessibility of those drugs and the affordability?
Yeah, so the first patient, this one, where he have been living like 200 kilometers from the hospital, so around Obbo, where he is a driver. So he sold his car in order to be afford for the surgical excision and the treatment, which is itraconazole. He have been over the past like 6 to 8 years. So this was a patient who want to go treatment to have a better treatment in Sudan. So the medication that they are buying is not affordable for most of our patients, as they are low socioeconomic status. So most of patients came from Afar, which is again the northeastern part of Ethiopia. And we have been seeing patients from different new focus of areas. So this is from the northern part of patients, this is the southern part, and this is one patient who live also in northeastern part of Ethiopia. So this one came from the Afar region, which is again bordering region with the Amara region. So we have patients from different areas, and most of them are not actually affording the medication. Then the other thing, the DNDi team raised was the itraconazole that is on the market. So it was it will be found in the downtown in the private pharmacies, and some of them were found to be substandards. We don't have a WHO or FDA approved itraconazole medications. That was also another challenge.
Can we see the photo of the patient with the leprosy as well, please?
Yeah.
Yeah.
Yeah, this was a patient who had leprosy lesions, but he came after a long time with lesions like this.
Was the leprosy diagnosed, confirmed?
Yeah, it was treated like 10 years back. This is a leprosy referral center in our setup.
Yeah.
He took the MDT, but currently, over the past 2 years, he came with lesions like this.
Do you think he used to have leprosy? Does he have a sequelae of leprosy, Wasan?
So he
has
has
a sequelae of
new
leprosy.
draining sinus.
Like, does he have, because historically as a dermatologist, you may just ask him for reactions and any disabilities and so on. Do you think he has that, or just they have misdiagnosed him?
Yeah. This was a patient who was admitted like, again, like a leprosy patient, as based on my evaluation. I also doubt that maybe he was having a mycetoma lesion from the initial, but he was mentioning numbness in the hands, and he was treated with MDT. That was also my consideration.
But he doesn't have any neurologic sequelae.
No, he don't have.
Okay.
Yeah. So let us, because having leprosy and mycetoma is not very common.
Again, Professor Fahal, you are a bit far.
Yeah, having mycetoma and leprosy in the same patient, not a very common presentation. Having tuberculosis and mycetoma, not very common. In the past, we used to see a few cases combining mycetoma, leprosy, mycetoma, and tuberculosis. But this is not very common. So I think let us consider the diagnosis of leprosy in this patient. It may be from the start, this is a mycetoma lesion, and then he was misdiagnosed as a leprosy as well. So let us confirm the diagnosis.
Yeah. Okay.
But I don't have any question.
I can see grains here in the lesions. This is clearly, this is mycetoma.
Yes.
Yeah. And do you frequently see, like, after this patient who has an amputation like 4 years back or 3 years back, but came with new lesions above the knee?
Yeah.
Do you frequently see them?
It is very common to have, because there may be a subcutaneous spread of the infection or by the lymphatics. And after the amputation, he will develop again the lesion at the cyst site. Not very uncommon to have this presentation.
Wasan, if you remember, we have some patients with mycetoma when you were a student with sporotrichoid distribution. The one also have shown us on the lymph node and the leg involvement. It looks like they have like a metastatic or diffuse lesion. So it is, you can see it's.
Yeah.
And yeah. Kadima, did you come?
Yes.
Do you have any question? If that's just notes, we can proceed to the next presentation.
Okay.
Okay, thank you, Wasan, for your great presentation. I think we leave the floor to the others.
Okay, thank you very much for this wonderful presentation, and we would like to proceed to the next part of this class for today, which according to our schedule will be discussing number 2. We are going to have a discussion on the presented topic, and this has been done. Now we are going to speak about news and updates by Dr. Arij Abdelmunem. So please, Dr. Arij, if you are here, please go ahead. The floor is yours.
Assalamu alaikum. Hello, everyone.
Hello, Reed.
Do you see my screen?
Yes, but
we do.
put it on presentation mode.
Okay. I'm happy to meet you all. My name is Arij. I am a pharmacist and a pharmaceutical analysis researcher. I am pleased to meet you today in a brief session highlighting the recent news and updates from the Mycetoma Research Center. Is the presentation working?
Yes, yes.
Can you see the pictures?
Yes.
Okay, that is good. The objective of this session is to share the recent news and updates from the Mycetoma Research Center activities. Our agenda includes UNESCO workshop on the use of artificial intelligence and information technology in scientific research and higher education, especially in the ongoing conflict of Sudan, the Mycetoma health campaigns in Kassala State, and finally, the recent research publications from the Mycetoma Research Center. First, the UNESCO workshop on artificial intelligence and information technology in scientific research and higher education. The UNESCO organized a workshop gathering a group of highly qualified specialists and scientists in higher education, scientific research, and information technology. This workshop was to brainstorm the use of the artificial intelligence and information technology in the scientific research and higher education. It was held in August 7th at the UNESCO Regional Office of Egypt and Sudan at Cairo. The purpose of the workshop was to discuss the integration of the artificial intelligence and information technology in scientific research and higher education. By the end of the workshop, priorities and goals were identified and proposed for future initiatives. Second, the Mycetoma health campaigns in Kassala State. 2 health campaigns were held in August 3rd in New Halfa and July 20th in Kassala. The goal of the campaigns was to provide medical care and raise the awareness for mycetoma in New Halfa and Kassala. These campaigns were done in collaboration with the Ministry of Health, Kassala State, the Federal Ministry of Health, and the Mycetoma Research Center. The 2 campaigns included X-rays, ultrasounds, lab tests, surgical interventions, and treatment plans, public education on the disease and prevention and care, and the impact of them was to enhance the community and to raise the health awareness in Kassala and New Halfa. The recent research publications from the Mycetoma Research Center from the beginning of 2024 to July. As we can see, we have numerous publications in these months. About 18 publications were published already from January to July in highly reputed journals, and the rest of the 25 articles are in the press. The publication highlights the following topics: the genome sequencing of mycetoma strains, the use of artificial intelligence to improve the mycetoma management, a roadmap to the UN Sustainable Development Goals by 2030, the causative agents of EU mycetoma and their differences in grain formation and treatment response, how to test the testing techniques of mycetoma species, and novel promising compounds with activity against Madurella mycetomatis. And lastly, literature reviews on mycetoma from Somalia and Burkina Faso. As we see, these are only examples from the recently published articles in highly reputed journals. The most important of these journals is the recently published phase 2 randomized double-blind clinical trial on the use of fosravoclonazole as a treatment for mycetoma, recently published in the Lancet Infectious Diseases. We will explore this study briefly in the following slides. It's a new treatment option for mycetoma, evidence-based findings and clinical implications. Introduction included the definition of mycetoma as a fungal implantation, mycosis leading to clinical manifestation. Mycetoma was reported in 102 countries, including Sudan. It affects foot and other subcutaneous tissues, impacting physical mobility, and clinically represented as a painless subcutaneous masses with deformity and loss of function, causing disability and stigma. The WHO classified mycetoma as a neglected tropical disease in 2016 and a fungal priority pathogen in 2022, which lead to the critical need for research and resource in fungal infections. The current treatments are unsatisfactory, requiring long-term antifungal therapy in combination with surgery. The first-line treatment for mycetoma is itraconazole, with efficacy rate around 40%, with a limitation of long treatment duration, leading to high patient dropout rate. Alternatively, ketoconazole can be used with a high risk of adrenal and hepatic toxicity. The clinical trial repurposed the use of fosravoclonazole, which was first developed to treatment of onychomycosis, and tried to use it for the treatment of mycetoma. The trial compared two doses of fosravoclonazole, 200 mg and 300 mg weekly, once weekly dose, in comparison with itraconazole daily dose in combination with surgery for both drugs. The trial was randomized, double-blind, and active controlled, conducted in Sudan. The efficacy of fosravoclonazole in comparison with itraconazole, as we can see from the histogram, itraconazole daily dose showed a higher efficacy against fosravoclonazole by the two doses, with no new safety signals for fosravoclonazole, but it has a lower pill burden as a once weekly dose, and reduced drug-drug interaction as it is only once a week. As for safety and tolerability, about 30% of the patients included in the study, 83 patients out of 205, showed adverse effects. Most of them were common, including bacterial infections, malaria, and influenza, which underline the need for proactive surveillance and supportive care. Only 2 patients showed serious adverse effect, leading to discontinue the treatments due to the serious adverse effect and not related to the medication. As for genetic diversity and resistance, the isolates of Madurella mycetomatis revealed a wide range of genetic variation, leading to a diverse population with potential clinical implications. The target gene, cytochrome B51, observed in the Madurella mycetomatis, showed no genetic changes over time, suggesting there is a genetic stability that may impact the drug effectiveness. The isolates from the patients showed no significant increase in the minimum inhibitory concentration despite the exposure to both itraconazole and phosphoroconazole, which indicates a low likelihood of developing resistance. The future directions include the need for new treatments with shorter duration and high cure rate in order to get the essential goals of treatment without the need of surgeries. Community education about early diagnosis, community education results in early diagnosis and timely treatment, which is very crucial to improve the patient outcomes and reduce the disease burden. The research must be continued to explore combination therapies, to study the diverse patient groups, and develop novel antifungal compounds. These are the key areas for further investigations. To conclude the study, both itraconazole and phosphoroconazole showed satisfactory efficacy when combined with surgery. The clinical implications include continued research and development of new treatments to improve the patient outcomes, and action must be done to promote early treatment and invest in clinical trials to address the unmet medical needs in EU mycetoma treatment. A final thought of my presentation is that Mycetoma Research Center has an ongoing commitment to research and community health and services. Thank you for listening.
Thank you very much, Dr. Arij, for this clear and nice presentation. And now the floor is open again for everyone who would like to comment, ask, or share any ideas. So please, if you have any questions, go ahead and ask your question. If you have any comments, it's free to add it now.
Mr. Windy, any comment about this study?
If you allow me, Professor Fahad, I think I have one comment regarding the future directions, which is, as it's clearly mentioned that we need new treatments. We need to look for better compounds and continue doing the research, and also the community education. But I think the community education itself is not enough, because we need to have this type of activities as we are doing now to educate our health personnel and our colleagues working in the treatment of the mycetoma. Because we know, all of us, we know that early diagnosis, early recognition, and early intervention is the key for the success of the treatment, whether it's a medical treatment or surgical treatment. And I appreciate if you can comment on that, Professor Fahad.
No doubt, early detection management, it is the key for the success of the outcome of the treatment for mycetoma.
Could you check your voice, Professor Fahad? It's a little bit.
I said that, no doubt, early detection, early management are the key for the successful treatment outcome. Early detection means field surveys, go to the villages where mycetoma is endemic, engage with the patients there, and then try to find the cases and refer them for management and for treatment. These patients are the poorest of the poor in poor remote countries, remote areas. So offer them free treatment, free investigations, free drugs is the important issue that we need to look for them.
Yeah,
thank you.
Perfect. And also education of those who take care of the patient at the primary care centers is very important, because some of the patient reach the primary care centers in their small villages, in small towns, but they don't get the correct attention, because many of these cases has been missed, remain undiagnosed, and treated for a long time until they become mandatory to be referred to the big hospitals to see those patients.
Yeah, absolutely right. That is why at the Mycetoma Center we had, or still we have 2 centers in endemic areas. one
Yeah.
in an endemic village called Unsa, and another center in an endemic village called Firdos, the White Nile State.
Perfect.
In these centers, we go as a team, we do surgery, investigations, ultrasound, and offer free treatment for this. And there is a lot written about this in our website. And there is a paper coming on the 22nd of this month on community engagement and the Mycetoma Center activities. I hope you can review that paper when it's out. Thank you.
Thank you very much, Dr. Okay, if you have any comments, please go ahead and raise your comments.
Dr. Abdullah, this is one day.
Yeah.
Can you hear me? Yeah, I just have two questions. The first thing is, how is now the registration of the drug going on in Sudan and with Hospital. And the second is especially with using the primary health workers. What's the experience? The one thing we are trying to do in Ethiopia is, because we have this, what we call it, the health extension program. These are usually women primary health workers, 12 grade plus one, who knows the basic health package, and we're trying to train them so that to help us with early screening in those area we thought will be higher prevalence of. But this is a project going on from our area, and we have trained some of those health extension workers, but still, especially the screening skill is very low. But we thought at least they can differentiate between Mycetoma and elephantiasis and other things, the commonest diseases. How is that experience in Sudan?
Yeah, thank you very much, Professor Windy. Regarding the registration of the drug, we have a temporary registration of the drug at the National Medicine and Poisons Board in Sudan. And this is a very good step for permanent registration for the drug. Hopefully, we're going to start an early access study with DNDi on 100 patients with mycetoma. And after that, we're going to have a permanent registration of the drug in Sudan. This is regarding the drug registration. The second, training of the health cadre is very important. At Sinai State, we trained almost all the health workers on mycetoma early detection and referral. The campaign was organized by the Ministry of Health at Sinai State. The governor of the state and the Minister of Health and that state were heading these activities. That is why almost all the nurses and health workers in Sinai State were trained on these issues. Some of them were trained on ultrasound examination for early detection and management of these patients. We need to have a good political support from the authorities to be part of the campaign against mycetoma. And as you said, integration of mycetoma and other skin entities is crucial to reduce time, to reduce budget, and to reduce the effort. And you can do a lot of things in combining these skin entities together in the campaign line. So I think we need to have more collaboration and to share experience so you don't reinvent the wheel, and you can start from where we start, we end it, and then you carry on for future collaboration. We need, Professor, to have a center dedicated for mycetoma in one of these villages where mycetoma is endemic, or one of the big cities where mycetoma is endemic. So you can attract a lot of patients, attract international awareness and donation for drugs for these patients. Doing campaign without giving this patient treatment is not very useful. Thank you.
Thank you, Professor Fahal. And the floor is still open for any comments.
Now the 6, Abdullah.
Okay,
Yes.
it's already now we are reaching the time for the conclusion of this session. I would like to thank everyone today.
No. There's
Yeah?
another. There is.
How many minutes?
Yeah, there is a presentation about funding, raising funding for Mycetoma.
No.
Okay, sorry.
Yeah.
Prof, we don't have it this week.
Sorry.
Because the time we're just we're sticking to 1 hour because we know everyone is busy.
Okay, sorry for that.
Okay, as we are reaching the end of this today's session, I would like to thank everyone who participated during today research club.
Professor
Yes.
Kadima was asking question. You don't give him.
Okay, please go ahead.
Professor Kadima. Kadima. I think we lost him.
I think he's not with us right now.
Yeah. And
Okay,
I would like to thank very much Professor Windy for coming with us and giving us the support and support his team.
Yeah.
And we look forward, Windy, to work together.
Yeah.
Thank you, Professor Fahal.
Yeah, it's actually a pleasure to have all of you today here, and I would like to thank every one of you for your active participation for today's session, and would like to invite you to the next week club. I hope that all of you will be here in the next meeting. Thank you very much, and I hope that you have a very good evening.
Thank you very much.
Thank you.
Bye-bye. Bye.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank
Thank
you
you.
so much. Thank you so
Thank
much.
you. Bye.
Have we on? Ang tangkang tayo.